Alison Moskowitz from Memorial Sloan Kettering, who is going to give us the pro side, and then Nancy Bartlett from Washington University in St. Louis is going to give us the con side for BV as part of upfront therapy. Alison.
Thank you very much. Thank you for inviting me to give this talk. I'm going to convince you that Brentuximab should be incorporated into the frontline therapy for most patients with advanced stage Hodgkin lymphoma. And I'm going to start with one of my patients who, shown here is the timeline of the treatment that she's gone through. In 2013, when she was 41, she was diagnosed with stage 4 Hodgkin lymphoma and was treated with ABVD. She actually had a Deauville 4 response, so she actually had a positive PET scan after 2 cycles of ABVD and continued on with ABVD and ended up having primary progression at the end of 6 cycles, and that was in 2014. And at that point, she was referred to our institution for further management. And we enrolled her on our clinical trial at that time with Brentuximab, where she received single agent at that time. She had a mixed response to that, went on and received augmented ICE for 2 cycles, had a complete response, and then in February 2015 had an autologous stem cell transplant. Unfortunately, just less than 3 months after transplant, she started having symptoms suggestive of progression with B symptoms. A biopsy of her liver in May 2015 confirmed that she had relapsed disease. And then she subsequently went on a clinical trial with nivolumab. In June 2015, had a partial response and actually remains on therapy to this day with active disease but asymptomatic. So how has this impacted her life? Well, when she was diagnosed with disease in 2013, she had to take a leave of absence from work because of the fact that she needed to get chemotherapy, and she didn't want to be exposed to the first graders that she would be teaching. And then when in 2014, when she was found to have relapsed disease and had to go on for salvage and autologous stem cell transplant, at that time she had to apply for long-term disability. In September 2014, when she was about to start treatment, she had to miss the first day of kindergarten for her 5-year-old. At that point, subsequently, when she was admitted for transplant, she was far away from home and actually had to spend 3 months away from her child as well as her husband. And then, unfortunately, when she developed fevers at the time after transplant, she missed her daughter's graduation from kindergarten. At this point, she remains on therapy and feels well, but the future is a little uncertain. If only we could have stopped this timeline a little earlier and let her have the rest of her time to make the choices that she wanted for the rest of her life. So what is the big competitor for Brentuximab AVD? Well, it's actually, according to the NCCN, the preferred regimen for patients with advanced stage Hodgkin lymphoma is ABVD using a PET-adapted approach. And that's based upon data from the RATHL study. And so the RATHL study enrolled patients with unfavorable stage 2 disease as well as stage 3 and stage 4 disease. And patients were treated with 2 cycles of ABVD and then were evaluated with PET. And those who had a negative PET scan were then randomized to either ABVD or AVD. And those who had a positive PET scan had their treatment escalated with BIACOP or escalated BIACOP. And for the PET-negative patients, the PET2 negative patients, their 3-year progression-free survival was 85%. And there was no difference in outcome for the patients who received ABVD or AVD. So the conclusion is that after 2 cycles of treatment, if the patient has a negative PET scan, we can take out bleomycin and reduce their exposure and therefore reduce their toxicity, their pulmonary toxicity. The PET-positive patients had a 3-year progression-free survival of 67%, which is certainly better than what we would have expected compared to the historical controls where patients continue on with ABVD. Now, the important thing to note about this study is that it did enroll patients with stage 2 disease. And in fact, 41% of the patients on the study had stage 2 disease. And so when we're trying to compare this to another study that enrolled advanced stage disease, we have to make sure that we know what we're comparing to. And the Echelon-1 study enrolled only patients with stage 3 or 4 disease, so only patients with truly advanced stage disease, and patients were randomized to receive either Brentuximab plus AVD or ABVD for 6 cycles. As you know, the study enrolled 1,334 patients. The primary endpoint was a 2-year modified progression-free survival, which I'm going to go into a little bit more, and then the standard secondary outcomes were looked at as well. So what do they mean by this modified progression-free survival? So It includes the regular type of progression-free survival, which means that if a patient progressed either on therapy or at the end of therapy, that was an event. If the patient died on therapy or at the end of therapy, that would be an event as well. But then there's also this modified event, which means that a patient could have residual disease on PET scan at the end of therapy and then go on to additional therapy. Now, if our goal of our frontline treatment is to cure patients with our frontline treatment and not give them additional treatment, our goal of our frontline treatment should be that their end of treatment PET is negative and they don't go on to an additional treatment. And so by including this additional factor where patients who had a positive PET scan at the end of treatment and then went on to additional therapy, we're really getting a true sense of how well this regimen cures patients with their frontline therapy. So I think it was important that they included this in the primary outcome. So who were the patients who were enrolled on the study? So again, I said it was only patients who had stage 3 or 4 disease, and actually the majority, there were slightly more patients who were male. The majority of patients were young patients, less than 45 years of age, which is what we would expect. The majority of patients had stage 4 disease. They had intermediate risk disease, and the majority of patients also had B symptoms. And it's actually these larger groups that seem to benefit the most from the treatment. So shown here are the primary endpoint from the study. So by modified progression-free survival, we see that there was a statistically significant improvement in modified progression-free survival for the patients who received Brentuximab plus AVD, with a 2-year progression-free survival of 82% compared to 77%. But again, it's the patients who were better represented in the study who seemed to benefit the most. So patients who were less than 60 were more likely to have benefit from the experimental arm. This was a little bit of a surprising finding, but patients from North America were more likely to have benefit from the experimental arm, and we can go into that a little bit in the questions if you'd like. Patients who had stage 4 disease, which again I said was the majority of the patients on the study were more likely to have benefit, and again the patients who were male were more likely to get benefit. So it is important to note that even though a higher number of patients were cured and the highest risk patients were more likely to get benefit from this treatment, there is toxicity associated with the Brentuximab plus AVD. And in particular, there are higher rates of febrile neutropenia seen with Brentuximab plus AVD. And when this was recognized, there was a modification to the study to require that patients receive growth factor with the treatment. And after that, the rate of febrile neutropenia reduced significantly and was no longer significantly higher than with ABVD. With regard to peripheral neuropathy, this is also seen more commonly with Brentuximab, which we would expect. But the majority of patients who developed neuropathy did have improvement, either reduction in the grade or improvement in the neuropathy towards the end, by the end of the treatment. And then finally, pulmonary toxicity, which as we would expect was seen more commonly with the ABVD arm and almost was not seen at all with the Brentuximab plus AVD patients. So what about the cost? A lot of people say, well, it doesn't make sense to give such an expensive treatment if we're not going to see a significant benefit. And I would say that the cost actually is justifiable because we are investing in a young patient population. And if we look at the cost, so the cost of 6 cycles of Brentuximab plus AVD is about $175,000. And no one can argue that that is certainly higher than what you get with ABVD, which is very, very cheap. And then you have the additional cost of growth factor, which I mentioned that you have to give with Brentuximab plus AVD. But when you look at insurance claims for patients who are treated in the community or throughout the U.S., which is regular ABVD, actually, most patients actually do already get growth factor with ABVD. It's not necessarily something that we always do, that I give, and we don't typically do that in the academic settings, but it is very common for patients already to get growth factor. So we can't necessarily factor that into the cost. And what about the cost of failing frontline therapy? So for a patient who then go on to salvage and autologous stem cell transplant, that's going to be a cost of about $200,000 to $300,000 in their first year. And then if they don't end up being cured with that treatment, then they're going to have ongoing costs throughout the next years to follow. And then finally, the cost that we really can't measure is this impact on society, which I feel is illustrated by my patient that I presented. And we're taking people who are very young, and we're taking them out of the workforce, and we're seeing a loss of productivity and significant stress on young families, which I think is something that is the reason why it is reasonable to invest in this patient population and give them a higher cost treatment. So, in conclusion, should most patients get Brentuximab plus AVD? Well, if you imagine that we have 100 patients with advanced stage Hodgkin lymphoma, and 64% of those patients have stage 4 disease, as was the case in the Echelon 1 study, and the other patients have stage 3 disease. And then a small group of those patients with stage 3 disease, we'd like to avoid giving bleomycin either because of their age or comorbidities. And so we get a few more patients in there. And so altogether, we have most of the patients with advanced stage disease being appropriate for treatment with Brentuximab plus AVD. So I'd say yes, most patients with advanced stage disease should get Brentuximab plus AVD. Thank you.